Have you ever wondered why some people get sick all the time, even if they are doing everything right? For many, it's something called primary immunodeficiency disorder, a hidden condition that affects the body's ability to fight off infection. Imagine being a child who's always tired, always sick, and doctors keep saying he just has a common cold, or an adult whose frequent visits to hospitals are often dismissed by saying it's normal. This is the reality of PID nowadays. But here's the hope: with early diagnosis, right treatment, and with proper awareness, life can change dramatically. And that's why we are here today to shed light on PID on this Primary Immunodeficiency Week. Hello, everyone. I'm Ritika, your host for today, and today we are going to discuss and dive in to a very important topic that normally goes unnoticed: primary immunodeficiency disorder, PID. Today, I'm extremely happy and glad to have our very own doctor, Dr. Priyankar Paul, MD Pediatric, Professor and Head of the Department of Pediatric Medicine, Unit Head of Rheumatology in the Institute of Child Health, Kolkata. So, hello and welcome, Doctor, to our awareness program about PID. And my first question, you can say that what is this PID and what are the symptoms of PID?
As the name itself suggests, it's basically some problem with the body's immune defense mechanism.
Okay.
So, the body's immune system is like the policeman of the body.
Okay.
They are supposed to give protection to the body, and they evolved over thousands of years to fight against the environmental pathogens, the bacteria, the viruses that we are every day getting exposed to. So, immunodeficiency means the body's immune system is not working properly.
Right.
So, some quantitative deficiency or qualitative deficiency.
Yeah.
And then you have a subset which is known as a secondary immune deficiency. So, which can be HIV is a classic
Yes.
example of a secondary immune deficiency.
Mm.
So, where you're not genetically immunodeficient, but because of some exposure to a virus or some drugs, you become immunodeficiency. So, that is a secondary. So, primary immunodeficiency, that is your genetically, you have a problem with the body's immune defense mechanism. So, that is a primary immunodeficiency disease. Now, primary immunodeficiency disease now is actually reclassified or as the inborn errors of immunity.
Okay.
So the present name is not a PID anymore. We call them the IEIs.
Okay.
So because it's the body's immune defense mechanism, so you not only if you have a PID or a IEI that you get infections, you're more prone to infections, but also the body's abnormal immune responses.
Okay.
So what we call an autoimmunity.
Yeah, right. Absolutely. So, what are the symptoms that normally we get to see when someone has PID?
Yeah. So if you look historically, the first PID was agammaglobulinemia, Bruton's agammaglobulinemia. So what is it? So bodies, the antibody, that is the gamma globulins. So whenever there's an infection, these are the gamma globulins give protection in many bacterial infections. So over here, you do not have the immunoglobulins or the gamma globulins.
Okay.
The antibody is deficient.
Okay.
So as years evolved, so we have discovered a host of PIDs or IEIs, and over the last 40-45 years, it has expanded really very almost drastically. Yes.
Yeah.
So presently, I think we have, according to the 2024 global that IEI classification, we have about 559 PIDs.
Okay.
And so, what are the symptoms?
Yeah.
So the basic symptoms is an unusual frequency of infection. If you just look at the basically,
Hmm.
so the child. So usually children are more prone to PIDs.
Right.
So it's not that PIDs are not discovered in adults. So a lot of people can be discovered in adults, but it's usually the pediatric age group which is predominantly affected.
Okay.
So they have an unusual propensity of infections, not only infections but severe infections, like multiple hospitalizations. So the child was admitted for a diarrhea. Again, after a few days, the child is getting admitted for a pneumonia. So what we say is unusual infections, unusual frequency of infections, severe infections. So normally a patient who would have responded very well to antibiotics, but this patient is not responding very well.
Okay.
So unusual severity of infections, unusual site of infections.
Right.
So like a liver abscess or a brain abscess. So normally those are sanctuary sites.
Okay.
Those are not usually affected. So if someone is coming with unusual site infections or an unusual pathogen,
Okay.
like normally someone would get some infections like a Acinetobacter infection. So they are not very virulent infections. So you are getting this infection. So an organism which is behaving very odd behavior for the abnormal behavior for the organism.
And what about the adults?
So adults, what you see is more of a CVID.
Okay.
So that is a common variable immunodeficiency. So they usually present a little late, and then again it's the body's antibody which is problematic. So that is in
That are
usually the
the
adults.
these
have.
are the common symptoms that
Yeah,
we see.
yeah.
As you said, this affects more to the children rather than the adults. Is there any specific reason for that?
So these are genetic disorders,
That's why.
and so a lot of this will present like if you have a SCID patients, which is known as a severe combined immunodeficiency. So where the T cells are not working properly and neither are the B cells. So they will have a very early onset.
Okay.
By 6 months of age.
Okay.
They will present.
Okay. Okay.
There's something known as a chronic granulomatous disease. They can also present by 6 months of age.
Okay.
And then the primary antibody deficiencies that we call that gamma globulinemia. So they will usually present after 6 months because the mother's antibody, the maternal antibody that they inherited, so that was giving them protection for the first 6 months of life.
Okay.
So once the maternal antibody is washed off, so then they cannot generate that antibody and they're getting the infections. So all this varies, and then there's this which is called autoimmunity because we are discovering more of autoimmunity nowadays. So autoimmune diseases again we usually see a little more in adults, but a very young child, maybe less than 5 years of age, coming with multiple autoimmunity. So fall in platelets, fall in hemoglobin, other autoimmune manifestations, vasculitis, associated maybe with infections, with lymphoproliferation, we say, because you are getting big lymph nodes. So then again, you consider possibly this is a IEI or a PID. So unusual, so early onset of autoimmune diseases, very early onset. Then you consider, and some malignancies also have been shown that they can be also associated with IEIs and PIDs.
Okay, thank you so much, doctor. So we already got to know कि children gets affected to PID more rather than adults. And the symptoms. And now my next question to you, doctor, how someone can diagnose PID in its early stage so that they
So
know.
first of all is the awareness.
Yeah.
So this is one subject which is still not unfortunately taught even in much in the MBBS course. So even in graduation, you are not learning much about the subject. So awareness is less even amongst the medical community.
Right.
So first is awareness building. So we are trying a lot now. So now we have the PID Society of India. So everyone is trying to build up awareness. So that is the first thing, that we should recognize that something is not right.
Right.
So that is the first thing, that recognition
It's very important.
important. And then only if you recognize, if you think, then only you investigate.
And then you diagnose.
Yeah, then you diagnose, exactly. So the first investigations that you are, if you are doing, Arhi, so you will have a look at what we call the lymphocyte. We can look at the blood counts. Sometimes the blood counts itself will give a just a basic blood count, a complete blood count, what you say. So like as I was calling a skid. So skid, they will have something which is known as lymphopenia.
Okay.
So
Fine.
usually they will have a lymphocyte count which is less than 3,000.
Okay.
So
less than
less
3,000.
than 3,000.
Okay.
Yes.
Fine.
So lymphopenia in the first 6 months of life with an infection, possibly it's a skid. So that is the first. You may be having low platelets.
Okay.
There's a disease which is known as Viscott Aldrich. So VAS will come with low platelets.
Okay.
So a low platelets in a male child, early onset with infections, is possibly a VAS.
Yeah.
So and then they have small platelets. You ask them to look at the size of the platelets, because in another condition which is known as ITP, where you also have low platelets, the platelets are big. So this is a very simple test which can give you an idea. Then there's something which is known as neutropenia.
Yeah.
So your neutrophil count is low.
Okay. Okay.
So that is again that you can look at the blood counts and say. Then you can have some specific tests like the immunoglobulin levels. You can do a lymphocyte subset analysis.
Okay.
So the lymphocytes, they have markers which is known as CD3, CD19, CD16, and so a lymphocyte subset analysis.
So these are the tests that are required so that you can people can be diagnosed with PID.
Exactly.
Okay. So now my next question to doctor is ki what happens in the body when someone has PID, and how common PID is seen in India? How common it is?
So if you look at the PID registries, globally a lot of countries, they have PID registries.
Okay.
So in India, we do not have any registries.
Mm-hmm.
So if you look at the global data, the global data is around 1 in 10,000. 1 in 10,000.
That's a huge number.
That's a huge number. But now, if you look at the Indian scenario, because it's a genetic disease, we have a lot of consanguinities in India.
Right.
And if you have a consanguinity, the incidence increases. So, rough estimate is that it's more than 2.5%. 2.5 per 10,000 population. So it is 1 per 10,000 globally, but possibly in India it's a little more.
More.
But unfortunately, again in India, because the awareness is a little less, we are not diagnosing a lot of patients possibly. What we diagnose is possibly what we call the tip of the iceberg.
Right,
So,
absolutely. Because it happens more in India, not be very hypocrite, but still, we get some problem and we just rush down to the pharma shop and go for any medicine. So that's why you don't get the right care that it should be taken. Now, I really want to know what are the different types of PID and how can someone suspect that they have PID?
Yeah. So, different types, you can have a cellular immune deficiency where the T lymphocytes are affected. You can have a T and B affected. So it's a combined immunodeficiency. Then you can have a neutrophilic problem. The neutrophils, what we call them, the podatics. So they are the foot soldiers. Whenever there's an infection, so the foot soldiers first go. So the first line of defense are the neutrophils. So you can have a deficiency of neutrophils, deficiency in numbers, or you can have a functional deficiency of neutrophils, like a disease which is known as chronic granulomatous disease, where they cannot really mount that burst, what we call that oxidative burst, to kill the organism. So the infection stays in the body. Then you can have complement defects. So there's a huge
different
sorts of PIDs. It's a huge number. and they can have varying presentations.
And as we already discussed that there are few symptoms and you said that, so how can you suspect in the early stage that yes, I am having PID or something like that?
Yeah. So one of the things is that unusual propensity or unusual frequency of severe infections.
Mhm.
So children normally get 5-6 viral infections in a year.
Hmm.
So they will get fever, 3-4-5 days of fever, so it subsides. So that is pretty normal. But an infection which is requiring hospitalization.
That is the
So
first
yeah, so
sign.
that is what we discussed. So recurrent hospitalizations, very severe infections requiring IV antibiotics, but or an infection which is behaving very deadly.
Yeah.
So those are the symptoms of PID.
Okay.
Or again, as I said, that because autoimmunity goes hand in hand with PID, very early onset autoimmunity.
Okay.
So
Okay.
those are the usual symptoms that a PID will present with.
Okay. Next, I really want to know from doctor ki what are the genetic reasons of PID and it can be inherited?
So all PIDs are genetics. So
Absolutely.
they all have a genetic basis.
Hmm.
Okay. So that is again one of the tests that we do to diagnose. So we look at the exomes, the whole exome, the clinical exome. So the final diagnosis of a PID or a IEI will be depending on the genetic diagnosis.
Okay.
But again, as I already said, that we are discovering new genes, new diseases.
Every
So
day.
even
Hmm.
over the last 2 years, a whole 20-30 PIDs have been reported globally. So
Okay.
it's a disease. It's a subset of disease which is still being understood,
Okay.
not only in India but globally.
Still
Yeah,
research
yeah,
is going
yeah,
on.
exactly,
Yeah.
exactly. But definitely, they all have a genetic basis. And regarding inherited, yes, of course. So genetic diseases are inherited. So, but you can have a new mutation coming up.
Mm-hmm.
But again, if you have a consanguinity,
Hmm.
the incidence of uh, inheritance will be much higher.
Right. My next question to doctor, how this PID symptoms vary from different types and also how PID can be diagnosed.
So, as I said, that you have more than 500 diseases in PID, and obviously, it's a very, very heterogeneous condition.
Absolutely.
So, definitely, there's a variation. So, some of the diseases, like as I said, SCID, so they have a very early presentation, very severe infections. Some of them will have what is known as the disseminated BCGosis.
Hmm.
So in India, all children, all babies will receive BCG at birth.
Okay.
So some of these kid patients, because they cannot control any infections, BCG is a live attenuated bacteria.
Okay.
So they will get a disseminated infection with BCG, which is rare, very rare. But again, you can have. So presentations will vary. Uh, like the T cell defects will have unusual viral infections. The B cell defects, they will have more of bacterial infections. Combined can have both.
Hmm.
So definitely the presentations vary.
Hmm.
Some of them will be syndromic.
Okay.
Some of them will have what you known as the HLH. So we have a entity which is known as a prime hemophagocytic lymphohistiocytosis, HLH. So some of these patients will, which is again a very inflammatory condition or a body's abnormal immune response.
Right.
So some of these patients will have what you know as a primary HLH. So they have a genetic defect which predisposes them to very severe HLH.
Hmm.
So some of them will present with thrombocytopenia, as a patient we discussed, a VAS patient. So definitely it's a very, very heterogeneous group.
Hmm.
So each, and that is how we diagnose, clinically suspect and diagnose.
Hmm.
So each disease will have some markers, but again, the final diagnosis will depend on lab investigations.
Hmm.
So the lymphocyte subset analysis, the immunoglobulin assays, some special tests need to be done, and then a genetic test. So genetic test will finally give the ultimate answer regarding the diagnosis.
Absolutely. Yeah. Next, I would request doctor to tell us ki how much time does it take typically to diagnose PID and what are the general treatments that we have to cure PID.
So, as I already said, awareness is little less. So, many a time, even the suspicion of PID is delayed.
Absolutely.
So, this child, you'll find that, and again, uh, we have all heard the story of blind man and the elephant.
Right.
So, five blind men and the elephant. So, if someone is feeling the trunk of the elephant, he will say something else. If someone is looking at the elephant's tail or the elephant's legs, they will say something
Different
else.
people,
Yeah.
different point of view.
Now, PID, because it's the immune system, they can have various presentations, various multiple presentations. So they can present to a general pediatrician, they can present to the subspecialist. So they can present just with chronic diarrhea. So they are going to the gastroenterologist, who may be just going on treating like a diarrhea and a IBD. They can present to the infectious disease specialist. They can present to the neurologist. They can present to the pulmonologist. So because it's a multi-system involvement, uh, if someone is not aware that what you are really dealing with, they can be just going on and on and on. So many a times, PID diagnosis are delayed because again the awareness amongst the medical profession is not that expected as what you would expect.
Yeah.
So sometimes even I think a lot of patients in the intensive care unit, especially in the pediatric intensive care units, they succumb also possibly without a proper diagnosis. And then again, because the investigations are little specialized investigations, the lymphocyte subset, the immunoglobulin, a little costly investigations at times. Genetics cost a little more. So many a time, even if we want to send the investigations because of lack of funds, it cannot be done.
Right.
So a lot of practical problems come into play while diagnosing PID. So majority of the times the investigation is delayed. So we
Yeah.
don't have a really basic understanding or a basic overall data regarding how long, but it's usually delayed.
Yeah. So not yet, but I hope very soon we'll
Yes,
get the
everyone
way
is
out.
hoping for that. Yes, we all hope for that. And regarding the treatment options,
Yes.
so first of all, they will usually, majority of them will present with infections. So they will require antibiotics. Usually, a culture should be done because we want to give specialized, the specific
Treatments.
antibiotics,
Yes. Yes.
specific targeted antibiotics. Sometimes unusual infections will require different antibiotics, not the usual antibiotics, and they will usually require in very high proportions, high because the body is not fighting the infections. It has to be because of the antibiotics. You have to give the highest possible dose and over a prolonged period of time. So that is again very important, that high dose, usually intravenous, and prolonged period of time. Sometimes you have to treat these infections for 4 to 6 weeks with intravenous antibiotics.
Okay.
Now that again calls for a prolonged hospitalization. So that is again something that becomes a little cumbersome, but it has to be done. And then other than the antibiotics, immunoglobulins are very important.
Is
Because
there any scope to avoid hospitalization?
no, if you get the infections, you have to get hospitalized. So prevention, yes, that is where the prevention comes in. So a lot of the PIDs are antibody, either there's antibody deficiency or the antibody is not working properly.
Right.
And there the importance of immunoglobulins. So not only as therapy, sometimes we have to give therapeutic dose of immunoglobulin, but as a replacement. So either usually monthly immunoglobulin. So that is very important, that if a patient has immunodeficiency which requires or which sometimes stays well with immunoglobulin, so that is very important, that like like a agammaglobulinemia, hypogammaglobulinemia, CVID patients. So that immunoglobulin replacement therapy, that becomes very important. And sometimes antibiotic prophylaxis, not only antibiotic but antifungal prophylaxis. So you have to be on possibly lifelong antibiotic and antifungal prophylaxis. And then again, for in spite of all this, some of the patients will go on getting life-threatening infections, and there the importance of the bone marrow transplantation comes in. So if you look at the definitive treatment, that is definitely bone marrow transplantation or
That
stem
is the
cell.
best way.
That is the definitive treatment where
Definitely.
you really
Yeah.
change your immune system. So a BMT. So that is the most important.
But that's very typical and very long process, you can say. So,
It's curative.
yeah.
It is curative. Of course, it has its hazards, but now all over India, a lot of BMT centers are coming up. Some of them specialize in PID BMTs. So that way we are possibly on the right path, but maybe more is required.
Maybe now it's not that much hustle to, get this bone marrow transplant.
Of course, no, it's a costly, it's an expensive procedure.
Yeah.
It's an expensive procedure. We have a lot of patients who are actually awaiting because they cannot generate that amount of funds.
Yeah.
So BMT is also not, it has its hazards, but again, that's curative. So we can have hope.
Any other alternatives other than bone marrow transplant?
Immunoglobulin replacement, as we discussed,
Hmm.
antibiotics, prophylaxis antibiotics.
Hmm.
So those are the usual treatment options.
And also it depends ki how soon our PID is diagnosed.
Definitely.
If it's in the early stage, then it's very easily curable.
No, again, if it's very early,
Yeah.
they are very severe disease,
Okay.
like the SCID.
Okay.
So over there, BMT is mandatory.
Okay.
It is not an
Fine.
option.
Okay.
So
Okay.
over there, BMT will be mandatory.
Okay.
Otherwise, it's very difficult for the babies to survive beyond
Okay.
infancy.
Okay. Next, I really want to know from doctor that what one can do when they are diagnosed with PID and what are the protective measures they can take.
Yeah. So if you have a diagnosis of PID, then the first thing that protection from infections.
Right.
So I think we are just out of the COVID period. We had some understanding, hopefully, of hygiene. So
Absolutely.
hand hygiene. These are the patients who should definitely wear masks if they are going to a public place, possibly even in schools. They are, the parents definitely should teach them the hand washing, the hand hygiene
The
technique.
basic
Yeah,
cleanliness. Yeah.
exactly. Uh, some immunizations should be done. Uh, Again, depending on the uh, what PID you have. So majority of them can be given the inactivated or the kill vaccines.
Yeah.
So immunization becomes very important. The seasonal flu vaccination becomes very important. The pneumococcal vaccination becomes very important. And then, and if this child develops any fever, because most of the times infection is
Yes. It's very
equate with
common.
fever,
Yeah.
so they should immediately uh, seek medical attention,
Right.
because their infections can just burst, so sort of it can just blow up.
Absolutely.
So that is a very important, that any infection, even in a small infection, can have devastating consequences.
And I was actually going to ask you, ki vaccination is very important to, make sure that your child is protected from PID.
Definitely. So these are definitely very important. And and if someone is on immunoglobulin therapy, so not missing the dose, sticking to the regimen. So these are very important. So you have to have a very disciplined regimental approach, sort of, that if you have a PID.
If you want to fight
Yes,
back
because it's a
to
chronic
PID.
disease. It's a chronic disease.
Yes,
Most chronic
absolutely.
diseases will require definitely a lot of discipline, lifestyle.
As we all know, with facts, myths also come. And now I want to ask doctor, what are the common myths that normally we, you deal or get to know about PID?
The commonest myth is that PIDs are rare. They don't happen. So, আমাদের হয় না. We don't have it in our country. So we don't have it because we cannot diagnose. So that is the biggest myth.
Yes.
That it does not exist. It exists. It very much exists. And a lot of patients, as I already mentioned, in the intensive care units are actually PID patients. Why is this children behaving such? They have such devastating infections. They possibly have some immune defect which may not be readily evident. So that is the biggest myth, that it is a rare disease. It's not a rare disease, and in fact, the estimates show that uh, it's commoner than congenital hypothyroidism. We do a thyroid screening test in all institutional deliveries now.
Yeah.
Routinely done. All newborn babies, they have almost all newborn babies will have a routine TSH done.
Right.
So that we are doing, but PIDs actually are commoner than a congenital hypothyroidism.
Okay.
So that is, so it definitely it exists, and we need to diagnose, and we need to treat accordingly.
So basically, it's like just because you don't see it, it doesn't mean that PID doesn't exist.
Exactly.
Without proper support, nothing is possible. And now I really want to ask doctor that how can general public support help in the awareness and the research of PID?
So this is one subject that is still overlooked actually.
Yeah.
Even in medical community. Uh, so I think all the subspecialists, we are not having a lot of specialty medicine. So all the subspecialists should be aware of PID because they can present with different subspecialists. And now regarding the general public, so a lot of funds are required. A lot of these tests will be a little specialized tests. They have to be done in specialized centers. Of course, government are building, but still, I think the need is much more than what we have.
Right.
So if we have some funds, definitely it is always beneficial. So maybe the NGOs or the corporates should come up with support.
Definitely.
So because majority of a lot of these patients will be on maybe immunoglobulin. Immunoglobulins are expensive in India, so lifelong immunoglobulin. Of course, I think there's a rare disease policy in India where you get immunoglobulin, but still again, investigations, hospitalization. So this is definitely a lot of money comes. They will require prolonged hospitalizations. Once they get an infection, a lot of them will land in the PICU. The intensive cares will require ventilation maybe. So these are all a lot of expenses. And then again, once you think of a different therapy, that BMTs or the stem cell transplantation, so that also incurs a lot of expenditure. So definitely, if awareness is generated, I hope that people will come forward with some funds to help
And
some
full
hospital.
support,
Yes,
and
yes,
together
definitely.
we can fight back to
Definitely, hopefully, yes.
PID. Now, as we come to the end of our PID awareness program, the last question that I want to ask to doctor is, what are the key takeaways of our session today?
So first of all, you have to accept the fact that primary immunodeficiency diseases, they do exist.
Yes.
Our awareness is little less. They are not uncommon. They are not rare. They are very much there. We are still understanding as a medical community the prevalence of the diseases, because new diseases, new genes are being discovered, and then they can have multi-system presentations. And any child who is presenting with unusual infections, severe infections, requiring recurrent hospitalizations should be tested for PID. And we have therapies, uh, we have definitive therapies also. So BMT is coming up in a big way in a lot of centers in India. So I think immunoglobulin is available. It's expensive, but it's available. Uh, Government is also looking at the rare disease program. They are giving support to the PID patients. So if you have a definitive diagnosis, so very important is to have a definitive diagnosis and stick to your therapy, and hopefully we will come up with a lot of success.
Yes. Thank you so much, Doctor, for such lovely and such knowledgeable session. I hope everyone is aware now about PIT. Lastly, I would request you to say something. Thank you so much for joining us in this beautiful session. And we were happy to have you today.
Thank you. And I feel that the fact that we are having this session shows that we really want to do something about it. We are really wanting to raise the awareness bar, and hopefully, with support, the governmental support, the industry support, and definitely with the support of the general people, someday we will also try to win over this situation. Thank you.
Absolutely, absolutely. This is the time we evolve, we change, we come up strong, and we win PID. Together, we can uh, win PID and we can change the world. So, see you again, all of you. Thank you so much, everyone, for joining us today. See you soon in our next PID awareness program. Till then, take care.
Thank you.